Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Peter Murphy from Mountain View Direct Care about the compass of connection, using moral insight to guide patient-centered care. Let's get started.
Hello, Dr. Dan.
Hey, Faisel. It's good to see you.
It is always great to see you and hear from you. And here we've got Dr. Peter Murphy. Welcome. We're so thrilled to have you.
Yeah, thank you for having me. Good to see you again, Dr. McCarter. It's always a pleasure.
Absolutely. Absolutely.
You know, you've trained in these large systems, from Harvard, Beth Israel, and now you're running a direct primary care practice in a small community up in Maine. But before we get into anything technical or anything like that, when was the moment that you decided that you had to build something different?
Oh gosh, 2010. No, really.
Oh, that was pretty specific.
No, that's the year I started medical school.
Oh.
So, what I'm doing now is the seventh iteration of, business plans that I generated over the past, 15 years. And honestly, I did the first one back then with Dr. Sean Reed researching direct primary care when it was more in its infancy 15 years ago now. And then over my career, I did iterations of it in medical school, towards the end of medical school, in residency, all right through the end of the residency, working with Lachlan when she was doing it. And I did a project right at the end there. And then, going to Boston and seeing, the heights of medicine was an interesting perspective to be practicing there. But it's been wonderful the past 5 years or so coming back to a small community.
So when you were a student, were you thinking more about the business of medicine, or was it more like the feeling of how it ought to feel? Well,
honestly, it was more the feeling, because I was drawn to the family medicine department because folks like Dr. Dan here and my other mentors at UVA Family Medicine, they were just the kind of old school, local country doctors who cared for their small town. And here, I'm not from Maine, I'm from Missouri originally, but I've been practicing the area for 5 years. And now, so I've got my roots here. My kids are in school here. And now being able to open a practice here is just amazing, because the feedback I'm getting from people, they're so excited.
I remember you were very interested in different business models. And I've got to say, not only did Peter do rotations with me, he was talking about Dr. McLaughlin he worked with her. She was actually worked with me as both a medical student, a resident, and then a partner in practice before she decided to move into direct primary care. So maybe I drive people away from the large health systems into that. But it's interesting because you were in a leadership position working on Medicare Advantage and value-based care, the way I understand it, and you then decided to make the move. So it's interesting. Over the years, we've seen a lot of providers moving towards leadership positions to get away from regular day-to-day care. And it looks like now this is a move in the other direction, which I think is pretty cool. I'd like to hear your thinking about that.
I can flesh that out, for sure. So with Maine Health, for the past couple of years, I had served in a capacity as their director for my local health system. They're what they call their director of high value care. So for value-based compensation models, or for reimbursement models where the Medicare Advantage plans are essentially shifting their risk to the hospital systems. The sales pitch being that we're going to do this, it's going to compel you to change your incentive structure and enable you with the cash flow and the benefits that are potential in those models to revamp the system, to go away from a fee-for-service model in healthcare. And so all across Maine Health, we've got 12 constituent health system hospitals and a whole swath of clinics. And for the past 5 years or so, we've been in a big effort to overhaul our entire system. And that's all well and good. And, you're trying to compel the system to move away from a fee for service system. You get away from the kind of perverse incentives on how we deliver care in terms of how the compensation is, where, if the hospital can deliver care at an efficient way in these capitated models, then they end up winning out. And we got the surprise message about a month ago that from the Medicare office in New Hampshire that literally every single plan in Carroll County, New Hampshire, which is where my hospital is, dropped Medicare Advantage. I had a quite geriatric weighted practice in my primary, so a big swath of my patients were Medicare Advantage beneficiaries. And we went from 22 plans to 2. And the only 2 that are available are if you're in a nursing home or if you're dual eligible for Medicaid. And so the other 20 plans and probably 70% of my panel just got dropped with no warning about a month ago. And, my decision, to your question, to transition to do direct primary care, like I said, this has been a lifelong goal of mine, but, seeing the way that the system is, for lack of better terms, collapsing around us it's timely. Because people need an alternative is the conclusion I've come to. They want to be able to choose something else where they can control their costs and they know who they're going to see and they know what the dollars are going to be at the end of the year so they can actually budget. Because where we are now, it's just unsustainable. Yeah.
Yeah, I can imagine for like the students and the residents who are listening right now, many of them are in just incredible amounts of debt. We are way past the 200,000, 250,000. Just this week I was talking to one of my neighbors about, his daughter is well over $400,000 in student loan debt. Just to hear that, and like with most of us, we go into medicine, we're not business savvy, you know what I mean? We're not financially savvy. We're just like, okay, we got this big mountain of debt and we just got to work, and we became doctors for the stability, right, that comes with all of that. And you can learn how to manage all the finances and all. But to hear this, that at one time 70% of your panel just had nothing to do with you. It really had nothing to do with the system. It was completely outside of all of your control. That's really terrifying.
It's absolutely terrifying, especially for these to be Medicare programs, right? These are entitlements, right? This is not an insurance program that people are purchasing. They have paid into this their entire life, and they got sold a bill of goods that these, because what is Medicare involved? It's taking our entitlement program and giving it to a private health insurance company and then having the health insurance company administer that program. And with the sales point being, you're going to get better care, you're going to get more comprehensive, less red tape and all of that. You don't have to deal directly with the federal government. But, lo and behold, if you give a health insurance company a big bunch of dollars, they're going to act like a health insurance company. And I'm pretty certain, what it really boiled down to is just, like I said, I had a very geriatric panel in my county. And by that virtue, utilization rates were higher just because of the demographics we have in the area. And when their bottom line took a hit, they decided to just leave. And for an entitlement program, just to be able to abandon an entire county of beneficiaries is just criminal. I don't even know how that's legal federally. It shouldn't be.
One of the things that I was really excited about learning this year was how in January 1st of 2026, that you could have your direct primary care practice and still take on other sources. You could have your insurance, your regular insurance and all that. So I'd love for you to be able to just, especially for like student residents who's just learning about all this stuff, this is big news, they're reading about it, and it's really scary. When many of them think about direct primary care, they're thinking about the cost, like of, the getting a practice going. It might seem very scary as opposed to something that may be much more comfortable and secure and known, like dealing with health insurance in general. If you could just quickly explain what makes direct primary care so fundamentally different from the regular billing models.
Well, I think what you're a couple of things I heard you say that you're getting at, it's a false sense of security that people have, that they'll be supported by this big insurance system. That maybe they will, maybe they won't. what this really illustrated to me, what I was just talking about, is that, when they're, they'll take care of you as long as it's in their best interest. And as soon as it's not, they're going to reevaluate their contracts and leave. And for that to be from an entitlement program, it's just, I just couldn't believe that. In terms of the prospect of direct primary care, as an alternative model, but honestly, I think it should be the main model for primary care going forward, because it really gets down to taking away everything that you have as a perverse incentive and throwing that away and saying, because all I want and all we want and all those medical students want is to take care of their patients, and they don't want to harm their patients. That's the oath we take. And if I harm a patient with a prescription or a drug interaction or something, that's one thing. If I harm a person with bankrupting them from a catastrophic bill that they were not expecting to see, that's harm as well, and that's completely unethical. And that's the moral injury that all of us face in the traditional system. And my advice to students is to really pay attention to that, because that really gets to your core. Like, if it doesn't feel good when you're doing it, you're fighting another prior authorization that's delaying care, or you're talking to patients about how they can't get coverage with their premiums went off the charts, and all of that. What direct primary care offers is a way to just realign the incentives and with the patient, with the doctor, to make it all in line with the patient's health. Because we want people to be healthy and happy. You can't be healthy and happy going bankrupt.
Right. Well, and I was going to say, I know I talked to you, I think it seemed like it was a Sunday afternoon. It was one afternoon you and I had a pretty good conversation, and I had an interaction with your virtual office assistant prior to that on social media. And so this really reminds me some of the Clayton Christensen disruptive innovation model, right? I mean, you had the whole computers, the Atari computers. They were basically little games that people played with. Faisel probably had one back in the day. And now almost all computing is done on personal computers. It just reminds me of some of the technological advances you have that actually help support you to have that kind of a practice and that kind of one-on-one relationship with your patients. I mean, it seems pretty cool to me. Can you describe some of the innovations that you've been able to put in place?
It is really cool. I mean, going back to students, the prospect of going into direct primary care, either later in your career or straight out, there's those financial barriers. There's startup costs. You're facing the prospect of being a small business owner. The way things that have developed now from my end is that I've been able to build a practice where I've got a fully comprehensive electronic medical record that does everything, that does enrollment, that does scheduling, does records, that does billing. All of it is in the cloud, and I pay $300 a month for that, and that is as comprehensive as Epic. And you've got health systems paying,
a lot more than $300 a month.
A lot more than $300 to get that. And yes, there's a lot of bells and whistles, there's a lot of functionality in Epic, but it honestly doesn't always add to the value that you're delivering to patients. And what we're able to do is have a small office with close relations with your provider, and you can run a streamlined practice on a very, very shoestring budget. It's not the days where you've got a huge overhead, you've got dozens of staff, particularly being in direct care where we don't have to have a whole set of people doing insurance, a whole set of people doing authorizations. And so it makes it feel like how you imagined medicine should feel. The doctor's office that you grew up in, that your parents have been going to them. You went to them their whole lives. They cared for your family, your grandmother, your children, and there's nothing between you and your doctor because there doesn't need to be. And honestly, pulling those third-party players out of the mix, taking these middlemen out by removing the health insurance aspect of it, it frees me because I'm not beholden to their rules. I'm only beholden to my ethics and what the patient's needs are. And from the patient's standpoint, it simplifies things too, because they can get the care that they need. at the time they need when they need it. And they can also do it in a way that they can budget their year and not be surprised by, something that could potentially bankrupt them. To get what you actually need. What you need is a conversation with your doctor for an hour about your health. You don't need a 5-minute visit and 15 specialist referrals. And that's what people end up delivering in the traditional system because we're forced to. If you get squeezed in with a shoehorn to do a 5 to 12-minute visit and try to do the care for complicated individuals, it's just impossible. And everyone is dissatisfied. To be able to do it with the direct care model is just a breath of fresh air. What they need is time and guidance and the ability to take ownership of their own health. And to be able to do that in our current, fee-for-service model in the traditional insurance system, it's very hard to do. I mean, I saw people do it at Dr. McCarter's office in Virginia, and those are the practices I'm trying to emulate. But across the board, it's extremely hard to find these days. And so what we've seen in Maine that's been very refreshing, we've seen a proliferation of primary care doctors leaving the system and doing what I'm doing. And I'm one of probably 24 doctors across Maine that leaving the traditional system have been opening direct care practices and just caring for their patients how they were trained to care for their patients.
Yeah, I think about like when I first started practicing out of residency, I didn't even know how to bill. I'm hearing, as I'm speaking with you, I was thinking, we had such a concern about the billing model and getting into something stable. But then we had to learn the billing model. We had to learn all the quality stuff, like, all that. I was like, and then you throw in, in residency, we had the 340B. We didn't know how much medicines cost and stuff like that. So then you had to throw in prior authorizations and all of that. And it's like you said, it's like such busy work. It's so like the core of it all. We just want to take care of people. Got to earn the trust and take care of people. And then you get out into these systems and you're seeing like 20, 25 strangers like every day. And maybe you'd be lucky to see them every 2-3 months if you're lucky. I mean, many of us weren't able to. There's just such a huge demand. But what you're describing is just so simple. You get rid of all of that. And we're living in a time right now where, like Dr. Dan was saying, he was interacting with your virtual assistant, which you couldn't have imagined doing 10 years ago.
Yeah, well, I guess what that gets is the way that the traditional system is structured. Patients are completely fly blind, but for the most part, and what they need is a guide, and that's how what does doctor mean? Right? It means to be a teacher, and to be able to guide somebody through the system to be able to get the best outcome that they can for their health. I mean, that's what the job is. And what I was thinking about when you were just talking is how we, doctors writ large as a medical community and a medical educational community. I mean, there's some signs of light in this, but across the board, we do a very, very poor job on educating medical students on the business of medicine, right? And when I think about it, and over the past decade of my practice, what is the source of the majority of the harm that I see? It's financial, it's social, it's psychosocial. We don't have a full picture of people's health if we neglect those issues. If you take a patient just as a human body and treat a disease and get an outcome, that's a disease-oriented outcome. That's not a patient-oriented outcome. And, what the patient's orientation is their entire life. It's their health, it's how they feel, it's how their body's working, and it's also everything else in their life. It's leaving the office and all the bills they have to pay and figuring out how they're going to budget for the rest of the year. And it doesn't seem to be getting easier across the board. And so we as doctors, we're doing our students a big disservice by not teaching the business of medicine, and how that impacts patients and how different payment models and different insurance models impact patients differently. Because it's honestly an ethical crime to have, I took care of, at my practice I just left, 2,000 patients, and to have one swath of them being affected in a certain way by a certain set of insurance companies, another swath by another, certain by Medicaid, and then people that are paying out of pocket. All of these groups are having a big difference in the determinants of health for what, how had the outcome that you want. So if I'm going to go from every patient across that spectrum and treat them the same way, I'm doing them a disservice, right? Because you cannot get the same health outcomes with an uninsured population treating their hypertension as a highly insured, highly utilized, resourced population. The disparity there is huge. And for us as medical educators not to focus on that in our educational models is unethical.
You bring up a great point, but it's I mean, Faisel and I, when we've talked to residents before, we've one of our taglines is it ethical to not consider cost? So you have somebody trying to get by on $1,000 a month or $1,400 a month of Social Security, and you think, well, they're the best drug for them, according to the guidelines, is a GLP-1 drug that costs, even if they have to pay a 20%, and they're in a situation where they can get it and only pay a 20% copay, it's about $200 a month. Well, $200 a month on a $1,400, when you're only getting $1,400 and you're trying to pay for rent and food, and where does that $200 come from when we write that prescription? And very often they feel embarrassed to talk about it because somebody has told the doctor, well, you're supposed to practice medicine without regards to cost. And it's to the point we almost have to look at it, not saying it's the right thing to do, but you're not going to get the outcomes without, if you're giving them a drug they can afford, you're not going to get the outcomes they need, because now they lose their house and now they're on the street. I'd far rather them be on a 40-year-old diabetic drug and with a roof over their head, especially in Maine, than I would be out on the street somewhere, right?
Absolutely. And I would go further and say, and I said this in my previous comments, like, I feel strongly that it's not ethical to ever practice in a cost agnostic way for the patients, because the analogy is, we spend a lot of time in trainings are about, culturing your relationship with your patient, your rapport. If people are going to trust your advice, great. If you're giving people advice and they don't want to hear it, or they don't trust you because they don't have a relationship with them and they're not going to follow your recommendation, what's the point? And the same exact thing happens with cost considerations. And for us to neglect that and say, okay, I want to prescribe you Eliquis because Eliquis has the best results for, efficacy and safety for prevention of stroke in, post-stroke patient or a PE patient. And they're just not going to take it because they can't afford $600 a month. And if we send them through the whole rigmarole with the cost coverage, we're Safety Net Hospital where I was, and we've got programs that can help alleviate that, but it creates so many different hurdles that people have to go through. And you have people either throwing their hands up at it and just taking nothing and coming back to me 3 months later and saying, well, I couldn't afford it. I didn't want to follow up all those phone calls and go through all the things. I took an aspirin, but you didn't call me and say, well, let's switch to Coumadin because that's more cost effective. But you put that on patients' shoulders, and exactly what you got to, Dr. McCarter, is that patients are stigmatized by this, for their ability to speak up and be their own advocate when it's something that has to do with cost coverage. There's a lot of shame involved. You're like, I can't afford this medicine. How am I going to afford it? Do I need to ask for special assistance? We're putting people in positions that, from their standpoint, puts them in a morally disadvantageous position where they feel less empowered as a patient. And for us to practice that way is not we need to take the whole picture and say, I want the best outcome for my patient. I want my patient-oriented outcomes to be my guiding light. I want my patients to do better, live longer, live happier. They can't do that, like you said, if they're bankrupt on the street, but they also can't do that if they feel afraid to talk to their doctor because their doctor's prescribing them things that cost hundreds and thousands of dollars and that they can't afford, and then they're ashamed to say, I can't afford that. And then they just don't get it. And then they're just left at risk, and you're left unsatisfied as a clinician, where I'm not delivering the best outcome that I could for this patient if all things were created equal. So, I honestly think it's morally incumbent on all of us as physicians to change how we do medicine, but it also changed how we do medical education.
I'm hearing you talk, Dr. Dan, like as he's speaking, like I'm in the end of the year quality sprints and all that stuff, right? Like I've been thinking about this, like this is how the insurance company is going to measure how good of a job we've been doing. And here he's talking about, he's like, hey, direct primary care, it's the relationship that's the intervention. But how do you define quality though, without all the metrics, quality metrics that we have been defined by the payers, right?
That's a good question. I guess the other question would be like, why do we need to define quality with a measurable number? Is the quality of our care really determined by how many people's A1C is under 7? If that is the metric, it boils it down to an impersonal, unsatisfying simplification of what we're doing. What we are doing is trying to teach our patients to be healthier, happier individuals that can live longer and have more fruitful lives. And that is not determined by, the percentage of my patient panel that is meeting their hypertension metrics based off of the electronic medical record data scraping.
I think there is at the population level evidence that if you do better on a population managing their blood pressure or managing their diabetes, you get better outcomes. But it reminds me of you were talking about the evidence-based medicine, and it reminds me of Dave Slauson, who is Peter and I both know well, and he is one of the gurus in evidence-based medicine. But he wrote an article about clinical jazz, and he would describe the evidence, and we could probably put the quality measures in there. That's the backbeat, right? That's the rhythm. But then jazz is not about that. The jazz for each individual patient is how do you take that as the jumping off point for what that patient needs. And at the end of the day is if you're truly doing direct primary care and the individual patients are entering into individual contracts, they're the payer, and then they get to define what quality is for them. Where I've heard some of the DPC docs talking about it's a little bit of an issue when they go out to contract with employers. Employers are being told by their consultants, well, how do you know you're getting good outcomes on the management of your patients for these conditions? And that's where that question comes up. Although I bet that in indirect primary care, I bet your numbers probably hold up pretty well compared to anybody else. If it truly looks that way, knowing you,
I would say the studies typically do show that, yes.
Yeah.
For DPC docs in general, and then the reason they do is because you have the ability to have a real relationship with the patient. You got to troubleshoot their side effects. You got to navigate their, what they're bringing to the table in terms of how they view their health, how they view medicines, how they view taking medicines, their financial considerations. So like all of those things are additional discussions that take time. And in our traditional system, the fee-for-service model, going through 10-minute visits, 7-minute visits, you don't know those things about those patients. If you do, you're behind and you're an outlier, and you're going to have HR powers that be in the venture capitalists coming and talking to you about your throughput rate. And going back to what you were saying, Faisel, about talking to students and like where they want to go in their career on the outlook, looking at direct primary care as an option there. I would encourage everyone to follow the path where their heart leads. If what you're doing is causing a moral injury, and the system that you're in is causing a moral injury every day because of the way that it treats people and the way that it neglects all the things we were just talking about, all those social determinants of health that are not part of the quality metrics, that gets to people. I mean, that honestly is a big part of direct primary care is saving the doctor's lives in addition to saving patients' lives. We, as young clinicians, as students, as prospective students coming into it, are coming into it with good intentions. I mean, they're people who want to care for people. No one goes through the decades of rigorous things that we go through without having that as part of their core. And if we don't build a system that sustains that and then keeps that, what we have is what we have now. And what we have now is dire. It's ugly to acknowledge the fact that every single year we lose a full medical school class worth of physicians to suicide. That's a fact. And for us to act like we're operating in a way and having a medical education system operating in a way that really does not get to the heart of that is, well, we'll reap what we sow. I highly, highly value and ultimately grateful for my education at University of Virginia because it focused on these core things. It focused on the patient-doctor relationship. It focused on having a broad view, understanding what the social determinants are to people's health, being able to talk to the patients, and making them understand, what's making them sick and how they can change that. But for the doctors going through it, the young doctors in particular, going through the rigor that we go through, all the difficulties we go through, you have to find a way where you can sustain yourself. And what is ultimately sustaining medicine is what we all know is that bond that we have with patients where we can care for them, we can care for them through something terrible. And if they get better, wonderful. If they don't, we're there as their support and their teacher. But if we're going through that and the system is putting, they're harming them in ways that would be preventable from a systems perspective, what whittles away at our core, I think, as physicians are things like that. It's death by 1,000 cuts. It's not having time to talk to your patient when you need to talk to them about the last thing they said as an offhand comment that seemed really important because you've got 20 other patients waiting along because of this conveyor belt system. And if you could stop, slow down, spend an extra 20 minutes with that patient, figure out what is really getting to them, that is sustaining. And that is what makes this job what we love.
What I'm taking away from this is there is hope. There is a way to get paid to listen to your patients, and there's a way to follow your heart and do good for the world while you're able to do well for yourself as well.
Well, that's my goal.
Yeah, thank you so much for your honesty. My goodness. I mean, it takes a lot of courage just to be speaking so openly about all your experiences. I mean, I really do believe that you're proof that primary care can be relational again, and it's absolutely sustainable.
It's definitely sustainable.
Thanks again for joining us.
Of course.
What are your thoughts on the compass of connection, using moral insight to guide patient-centered care? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.